Everyone. Um, I, I know we're starting a bit late, but I do want to be sure and give a special big thanks to Mandy, Joss, Melissa G, and Melissa J. So I think we should all give them a great big round of applause for all their hard work in putting this together. I think it's been really fantastic for me, and I'm sure it's been just amazing for you guys as well to get to meet and make the connection. So really a special, great big thanks. It's been a really special weekend for me. So I'm going to start by just kind of telling you, so you heard a little bit from Josh, so I'll move through this early part quickly. So for people who are a little geography challenged, I'm in Houston, Texas. Houston is in the southeast corner of Texas, right on the Gulf of Mexico. And this green arrow is my office at Texas Children's Hospital, which is in the Texas Medical Center. And then that's downtown Houston in the distant background there from the medical center. So again, kind of just to start with a little bit of history, as you heard yesterday in some of the talks, there were a series of studies looking at large groups of individuals with autism or developmental disabilities. And these identified quite a large number of genes that were thought to be associated with autism, intellectual disability, or other neurodevelopmental traits. And you can see these here. In those publications, again, these were just gene associations, and there was not detailed information about the individuals that had changes in POGZ. There was also a cohort of individuals with schizophrenia, one of whom, again, had a variant in POGZ, but again, these are large studies, and they weren't really entirely definitive. And so, as Josh had mentioned, so I am the clinical geneticist for a program that's now the Baylor-Greger Center. At the time, a number of years ago, was a joint research center with Johns Hopkins. Was funded by the National Human Genome Research Institute. And my colleague Jim Lupsky, whom I work closely with, works on a condition called Smith-Magenis syndrome. This is a genetic disorder of chromosome 17, and individuals with Smith-Magenis syndrome have sleep disturbance, behavior issues, they can have obesity, and so you can already probably start to hear some of the overlap. And so this individual was thought to have Smith-Magenis but did not have the typical deletion on chromosome 17. And so Jansen White, who was a graduate student at the time, presented at lab meeting that he had done what's called exome sequencing. So this is sequencing all of the coding regions of all of the genes. And he found in this girl, young woman, a change in the POGZ gene that was a change that's called a stop. You kind of heard some about that yesterday, and I'll talk about it on another slide, but that was not inherited from either parent. And so based upon these prior publications from autism and the fact that this was new in her and not inherited from either parent, we first suspected, well, yes, this may well be the cause of kind of what's going on with her, but also realized in discussion that this must be more than just an autism gene, right? That if somebody thought she had Smith-Magenis syndrome, that's, again, they have all these other traits or characteristics that we assumed that must be that. So we had this one individual, but again, as you might imagine, being scientists, that's often not enough for us to say definitively, right? So we have some evidence, but we don't really know for sure, and this is kind of one single individual. And so what we did is we said, we need to go look and see if we can find other individuals. So we have a very large diagnostic lab in our department where people from all over the country send us samples to do clinical testing. And you'll hear more about that on another slide when I talk about the frequency of this disorder. But so what we did is we went to our diagnostic lab database and we said, we want to see if there's anybody that has a change in this gene POGZ that's not seen in either parent. So we found 2 additional cases there. And then we approached another large diagnostic lab called Ambry Genetics and asked if they had any cases, and they said indeed they had 2 cases as well. So now we're up to 5 cases. But what we needed to do is figure out, okay, this is still a pretty small number of individuals. Are there things that we can see to really support that this gene is causing the traits that we're seeing? And so what we did is look at a number of things. So we looked kind of here at the top, the type of genetic change. So all of these genetic changes, as you heard yesterday, that kind of end in a star there or an asterisk, those are stop changes, and those generally are usually disease causing. We looked at, is it new? And again, in everybody where we had both parents to test, it was new. It was not inherited from a parent. When we looked at other things like behavioral phenotypes, learning issues, vision issues, again, that you've heard a lot about, we started to see this pattern developing that, yes, there are lots of similarities that we're seeing. We also saw this individual that had what's called a diaphragmatic hernia. This is a hole or a weakness in the diaphragm, and this is actually quite an unusual birth defect to have. So it was only one individual, but it's a fairly unusual birth defect to have. And then again, because Smith-Magenis syndrome has distinctive facial characteristics often, we wanted to take a look, and so I know some people are going to recognize people here, but we wanted to kind of take a look and see, like, are there similar facial characteristics like we see with many genetic syndromes? And so you can see individuals at different ages here, and you can see, again, kind of a lot of the similar characteristics. And so now we're starting to get pretty convinced that this is the case. And so in January of 2016, we published these 5 cases, and this gene, POGZ, that had only previously been potentially associated with autism, now having a syndrome with kind of multiple traits or characteristics. And then very shortly after, about 3 months later in March, a group from Europe published about 25 more cases. And you can see, again, kind of the similarities. And then when you add these individuals together, so the 5 from ours and then the 25 that were published a few months later from Europe, again, we've all heard all of this the past couple of days, but you can see it's actually pretty consistently held up. The numbers, you know, as Anna and others talked about yesterday, kind of change a little bit, but these again are small numbers, and you can see again pretty consistently the things about kind of learning issues, behavior issues, vision, overweight, and sleep concerns that are seen in these individuals. A couple of years later, working with one of our genetic residents, Reid, that's shown on the slide here, we worked with the White-Sutton Syndrome Foundation to try to get a little more information so that families would know kind of what to expect, and for us to kind of dig a little bit deeper into problems. So again, kind of Reid working with the White-Sutton Board of Directors, we developed a survey that was sent out. So again, I think this is a great example of how the foundation kind of started and continues with the Sanford group to really try to collect information to let families know what to expect, and also to help guide researchers into what are important issues that are seen that we really need to be addressing. And so again, I'm not going to spend a lot of time talking individually about these, but what we asked about development so we could get a good sense of the range of development. And so you can see that for many of the typical developmental milestones, that these are occurring a bit later. So if we just take the kind of SAT unprotected, that's kind of in the left, in the SAT unsupported, sorry, that's in the orange, Usually that occurs at about 6 months of age typically. This is more like 10 months of age. And again, kind of language also, again, you can see that first words, which usually occur, it's the middle gray bar there on the far right. First words that usually occur at about 12 months or so of age, again, are a little bit later there, more like 20 months of age. So again, just to give parents a little bit about what to expect. But the other thing too that you can see is there really is a big range. So you see some of these X's going way up. And so some individuals have slight delays in developmental milestones, others much longer delays in those. We sent out a questionnaire about sleep and GI, and you heard, again, kind of nice story about the GI yesterday from the, and then there's a cyclic vomiting talk later today that you'll also hear about. But again, just kind of reaffirming that these issues with constipation, cyclic vomiting, reflux, and other things, again, are issues, and I'll get to the importance of identifying that and discussing that in a moment. I'm going to move on to kind of talk a little bit about the genetic basis. Most all of these changes, as we've discussed, are what are called stop variants. So genes are instructions to tell our body how to make something. In this case, it's the POGZ protein. And you can have different types of changes in genes that lead to conditions. One of the changes is a misspelling in the instruction. So all the instruction is there. There's just a misspelling that kind of doesn't make sense. And then there are some changes that cause the instruction to only get halfway through it and then stop before it gets to the end. So it's not the full instruction. The vast majority of changes in the POGZ gene are that second type, the type where you're missing part of the instruction. So there are a few that are misspellings in the instruction, but the vast majority of them, and I'll show you on the next slide, are ones where the instruction just gets stopped. They also, the vast majority, are not inherited from a parent. A lot of times parents ask, well, how did that occur? Like, if all of my kids' genes come from me, how did that happen? The way that occurs is that when we are copying our genes to pass on to our children, and we're making a copy of each of the 20,000 genes that we have to put into the egg or the sperm cell to pass to our children, in that process of copying, the cellular machinery can make a mistake in copying. Now, the cells have lots of spell check machines in it to try to catch those, but just like with your spell check on your computer at home, sometimes those things get missed for various reasons. And so that's how this happens when a parent doesn't have it, but then has a child with a change in a gene. I should also say that I think probably everybody knows this, but just to be clear, we do not know of any significant factors that cause that to happen. So things that parents do or don't do before or during a pregnancy are not likely to cause a misspelling. The only thing that we know of to date that predisposes to misspelling is advanced paternal age. So when fathers are older, but again, that risk is still pretty low. The vast majority of fathers who are over 40 that have children do not have children with White-Sutton or other disorders. This is just showing, again, I think you've seen, but one of the things that's distinctive is that we do see changes over all of the areas of the gene. And so when we look at genes, the big dark bars there are what are called exons or coding regions. And then the thin lines that connect them all are what are called introns that are just kind of separating these coding regions. The vast majority of these, again, are these kind of stop changes, and they really are kind of all over the gene. When we've also looked as well, and you, again, heard this from other groups yesterday, that we can't, there's no particular type of change or region of the gene where the change occurs that predicts what an individual's experience is going to be. And so you can't look at a change and say, you know, they're going to have sleep apnea, or they're going to have bad constipation, or they're going to have more challenges with learning. Unfortunately, when we and other groups have looked, the change is not able to prevent that. There also sometimes are hard to find changes that are in non-coding regions. So this is an individual that I worked with, our Undiagnosed Diseases Network group, who had a change in one of those introns, the non-coding regions, that was hard to find. And so there are these rare other types of variants. One of the other things people ask a lot is how frequent is this? And so one of the other projects that the resident Reid did was, again, to go back to our diagnostic lab. At the time she did this in 2019, the diagnostic lab had performed over 12,000 exome tests on patients. And so we wanted to try to look and see, okay, it's been a couple of years, the lab's been reporting out, since the beginning of 2016, so 3 years or so, these changes in POGZ, and now we want to go back and try to get an estimation of the frequency of that and how often does it occur. And so we searched the lab database using various terms like developmental delay or learning disability or autism spectrum disorder to do that. And so again, I'm not going to go through everything on this slide, but you can see that it is a pretty small number of cases that in total, from the total of 12,000 where we were able to identify this. And so basically, kind of when you do the calculation of individuals with autism or developmental delay or intellectual disability that were referred to our lab for testing, only about 1 in 550 of those had a variant in POGZ. So it is, again, as you've heard, and as everybody probably knows now, it is a rare disorder. I'm going to now move on to talk about some things when I talk with families that are, I think, are important to consider. One is therapy services. We certainly know for other common genetic disorders like Down syndrome that the earlier you start therapy services and the more consistent you are about therapy services, the better the neurodevelopmental outcomes are. And so really starting early, most states have some sort of early childhood intervention program that usually occurs for the first few years and then transitions to school where individuals can get therapy services. Seeing physical medicine and rehabilitation to help with things like mobility. If there's loose joints, they can do things like shoe inserts or things to help with walking. If they have stiff joints, to do stretching, and again, working with physical therapists and others for balancing and other things. And then when they get to school, again, communicating with the educators there about needs, and I'll show some resources on the last slide for that. There are various things that can be done for behavior. Certainly if there are autistic features, applied behavioral therapy analysis, or ABA, can be used working with a psychiatrist or a neurologist for medications or other treatments to reduce anxiety. Obviously, if they have seizures, working closely with a child neurologist to manage seizures. When we've surveyed parents, there's not one particular seizure medication that tends to work better than others. You heard from Anna yesterday about the seizure medicine perampanel, which again may potentially help with behaviors as well, so that might be a consideration. And then education, particularly if your child is cared for by others, grandparents or other people, that to be sure that they're alert to the potential of seizures and what those look like. Hearing and vision testing, since again we know those can be issues. And again, many states or schools have vision therapy services or hearing if that's an issue. As again, you've heard, sleep disturbance is common in at least probably a third of individuals, if not more. This can be diagnosed with what's called a sleep study. This is where typically kind of spend the night in a hospital or a clinic hooked up to a bunch of monitors. It's non-invasive testing. And that can help to know, again, A, if they have sleep issues, and B, kind of what the best treatment would be to help manage that. The sleep disturbance is not just a challenge for families, just to be clear, that if children or individuals are not sleeping well through the night, that makes them tired during the day, having trouble functioning at school, paying attention at school, making it more likely that if they're tired, they're going to have a behavioral meltdown at some point. And so again, it's something really important to be attentive to. Signs that you would see that are often kind of snoring a lot at night, particularly when they don't have an upper respiratory infection, if they kind of stop breathing through the night, or if it seems like they wake up frequently through the night. There are kind of supplements like melatonin that I've had some parents report that helps if they do have sleep disorders. If they have obstructive sleep apnea on the sleep study, an ENT doctor can remove their tonsils and adenoids. And then also measuring iron and ferritin. When that is low, that can cause restless leg syndrome, what's called restless leg syndrome, and can cause problems with sleep. For gastrointestinal concerns, again, you'll hear more about that from a GI expert, but for me, kind of often what I recommend to families is to, one, be alert and vigilant. We know that if you kind of catch something before it starts or early in the process, you're going to have be more likely to be able to avert it becoming a crisis. So talking with your physicians about having home medications and a plan for if you think something's coming on, the cyclic vomiting or other issues, to have medications at home for that. If there's a lot of constipation, again, you want to not kind of wait until there's constipation to treat. If they've really got problems with constipation, they need to be on something every day. And so working with your primary care doctor, or as there are various kind of things like Miralax or Senna that are natural, essentially mostly natural alternatives. And the other thing to be attentive to is water. So if you're not getting enough water, that's going to make you constipated. And then we were kind of talking with someone earlier about a feeding tube. I think, particularly if they're not just swallowing challenges, but challenges in getting medicines in or getting enough water in, a G button often can be very helpful. And I find parents often are anxious about doing that. It seems kind of invasive, but then many times after it's done, they really express a lot of relief that they don't have to worry so much about did they get all the medication in, or are they getting enough fluid or nutrition or those sorts of things. So it just kind of takes, a lot of times parents will say, again, like we were talking about earlier, like it just kind of one thing off your plate and one less thing to worry about if that's an issue. And then again, kind of we're all here today because of community support, which we know is very important, but also being attentive to weight and obesity, and engaged in activities like Special Olympics or other things for healthy lifestyle. These are some of the resources I was talking about. Obviously, hopefully everybody knows the White-Sutton Syndrome Organization website. There are these other ones. Gene Reviews is a very good one, particularly for medical professionals. And so, again, if you're a primary care provider or, physical medicine and rehab doctor or speech therapist or whomever it is, kind of has questions, this is a good medical resource to go to where they can read about the condition. It's at the National Library of Medicine and is free online. these other resources as well. And then for research, there is this website, clinicaltrials.gov. So any research in the United States that's either through the Food and Drug Administration, the FDA, or funded by the National Institutes of Health, that has to be listed on this website. Most people, even if it's not required of them, do list it there because that's kind of the single clearinghouse for that. I know we have a couple of international families. Even most international studies wind up listing it on this website. So I'm going to stop there and say thank you to everybody who helped me. So this is Jansen White, who long ago got his PhD and graduated. The funding now for our Greger program from the National Human Genome Research Institute. My colleagues Jim Lupsky and Jen Posey, who are the leads for our Greger program. And then you'll see I had a lovely trip to Trieste to attend Anna's thesis a couple of years ago, and I'm glad she's still working on everything. So I'm going to stop there, and I'm happy to take any questions.
Any questions? Hi, I was wondering, how common is it for you to see two individuals with the exact same variant?
It is not very common. It does happen. We do see some that have the same variant, but kind of on that slide with all those little sticks coming up off the gene with the colors, there are a lot of different changes. There are certain disorders where there are only a couple of changes that are seen, and there are even certain disorders where there's only one change. So there's a condition called achondroplasia. So people are Game of Thrones fans and know who Peter Dinklage is. Peter Dinklage has achondroplasia. Everybody with achondroplasia has the exact same genetic change. This is the complete opposite. Almost nobody has the same genetic change. There are many different changes that we see throughout the gene.
Okay, so then a follow-up to that, where you said that symptoms aren't necessarily defined based off of the variant. Is it because of just lack of knowledge and you guys aren't able to develop the patterns yet?
Yeah, I think that's a great question. I think it could be one that we just don't see that many people with the exact same genetic change. It is also a rare disease. However, you know, it is usual that if there is quite a bit of variability, that we can often say, well, if it's this kind of stop change as opposed to a misspelling, that's going to be worse, or if it's in, you know, this last part of the gene, it's maybe not so bad as if it's in a different part of the gene. And like there are quite a number of people now where it's been published, but we and others, when we've really tried to look, there's not a prediction. That's not to say at some point in the future somebody won't figure out the pattern, but we've certainly kind of been looking at kind of what would typically be patterns. We and others have not seen that.
Thank you.
Hi, Dr. Sutton, thanks so much. I know we've heard a lot this weekend, mostly about the stop mutations and nonsense mutations, and I'm wondering if you could just take a minute and share any general thoughts or findings about missense mutations as related to White-Sutton.
Yeah, I guess I would say I always tend to be a little skeptical about those misspelling changes. Particularly, you know, I would want to see that neither parent has it. There are things that labs can do, essentially like computer program bioinformatics sorts of things to try to predict. Or as I was showing on that research slide from the patient from the Undiagnosed Disease Network that had the change in that non-coding region, is for sure the disease causing. I think there's in the back there.
So you've been working since 2016 about that White syndrome disease or syndrome. What are one or two big questions you are asking yourself about the syndrome, and you're going to work on it for the next few years?
Yeah, so I think again, always the big thing, understandably, is that families obviously want to know what to expect or what they need to work on, right? So I think this kind of certainly one thing is like again continuing to try to see if we can figure out a pattern that we were discussing earlier that kind of predicts the future, right? I think that's one thing. I think one of the things that is a good start for the foundation again is this Sanford patient database that again I don't have anything to do with it, but I would certainly encourage everyone to sign up for it. I guess I do think that there are things that the foundation should be considering to work proactively with researchers and others to get research funding. And again, I know they're doing that. I think the collaboration with the Champ One is good. But as great a job as patient advocacy groups do at fundraising, it still can't match typically what the federal government is able to spend for research. And so I think that's really something that should be a strong focus.
So I'm pretty new to the POGZ. Just found out we have it in back in July. We haven't. How long does it take to, or do you know how long it takes to get confirmation? Or is it if you have the POGZ gene, you pretty much have the syndrome too?
Yeah, I think that's a great question. And, I think, so if you have a disease-causing change in POGZ, you have White-Sutton syndrome. But again, I think, not everybody has every characteristic. And so I think, if you look, we've kind of been, I think, on some level taking a pessimist look about, okay, a third have sleep disorders, half of people have constipation, right? But the reality is that means 2/3 probably don't have sleep, that, half of them are probably pretty good without a lot of constipation issues, feeding issues, all these sorts of things. So not everybody has every issue, and many people may only have like one or two issues.
Okay. And then my second question is yeah, you're talking about the different types. So mine is a dominant one. That's not a missense, right?
Yeah, they're all dominant.
Okay.
And it's just either is it a misspelling or missense, or is it a stop where it doesn't make the whole instruction?
So I would have to go back and look. Okay. Thank you.
My question is about med management. If we're experiencing symptoms that typical meds that would be prescribed by a psychiatrist are not working, do you have any sort of advice about where to move from there?
Yeah, I think both with seizures and the behavior issues, there's not one set of medications that really works well. One of the other challenges, I actually, on the way here, I got emailed from a child neurologist in AI DuPont Hospital in Delaware that like one of her patients, and I think it is a challenge. I think again, many years ago there were inpatient facilities where people could be admitted to a hospital for a week or two to try to get medications adjusted. Unfortunately, like you could certainly kind of check in your area with your neurologist if that's something that's available, but in many places that's that sort of residential kind of hospitalization for medication adjustments not really available, and really just kind of work like trying to find a psychiatrist or a neurologist that you can work with, and really kind of staying in close communication with them. I think many of us have electronic medical records where you can essentially kind of email through the electronic medical record questions, and so really kind of keeping them updated. Like if you make a medication change and a week later or 10 days later you're not really seeing much improvement, being sure that they're aware. I think this is a particular pet peeve of mine because my parents are particularly bad about doing this with their doctor, where they'll like prescribe something and it's like, oh, well, it's not working, so I quit taking it. I'm like, well, did you tell Dr. Bain it's not working? And they're like, well, no. I'm like, you gotta tell him, he doesn't know, right? So being in communication to say like, that's not working, we need to try something else.
Okay, thank you.
So I have a couple of remote questions here, and Rima, I apologize if I'm saying your name wrong, but Rima Husseini is asking, with all the symptoms of White-Sutton syndrome, like seizures, obesity, GI issues, have there been studies about late onset of them due to puberty?
Yeah, so I would say certainly the obesity issues are not really very common in childhood, that we tend to see those more as individuals move into kind of teenage or adult years. The seizures as well, like seizures kind of at or around the time of birth are not really very common. Those are kind of, if you're going to develop seizures, that typically tends to be kind of more in kind of early childhood, school age years when they would develop that. They usually are not the type of seizures that are difficult to control. In most people, if they do have epilepsy or seizures, usually kind of, you know, one medication is able to kind of get good control of them.
Yeah, that's been the case with our son for sure. Rima had one other question. Due to the fact that White-Sutton syndrome is a newer syndrome, is there any evidence of it being regressive like Rett?
No, the short answer is no. Yeah, so I've not heard from parents, and I've not seen in the patients I see regularly this regression like you see with Rett syndrome.
Great. Any other questions? Yes.
Hello, thank you. One of the things that I have struggled with is that my son has behavior issues, but he does not have an autism diagnosis, and we can't get ABA therapy. So like our neurodevelopmental psychologist has suggested behavior therapy, which it's not your issue, but through insurance is not an easy thing to find.
Right.
So do you have anything to speak on that? Or other suggestions for those that don't have the autism diagnosis?
Yeah, I do think it's a challenge, right? So there are lots of these things where in order for insurance to pay for something, there has to be a diagnosis, right? I mean, one option is always just kind of, you know, retest, like wait a year or two and try to have an appointment with, again, the neuropsychologist or the child neurologist or whomever at your institution does the testing to retest and see if they would qualify. But yeah, it's one of those unfortunate things that the same people probably experience with therapy services too. Often insurances have a certain set of diagnoses they'll pay for, or they'll certain number of sessions that they'll pay for, right? It's unfortunately a challenge of our healthcare system. I'm afraid I don't know how to solve, but like I would like retest. I wouldn't just assume that like you did it once and he doesn't qualify and he'll never qualify twice. Okay, sorry.
We'll be going. Yeah, I know.
Yeah, we have time for maybe one more question here because we got to keep moving, but
Hi there. I think you have maybe partially addressed this already, but I'm thinking of maybe one study from 2022 that tries to look at like the variants and then theorizes that, you know, something on the second half of the protein may escape decay and present itself differently. So I'm just wondering, would you, in your opinion, would that just be like, it's the start of evidence, but it's not enough to really like show any kind of pattern? Yeah,
so that's a very complex question. Let me go back to my picture here. So what we often see is if the change occurs in this last or the next to the last coding region, you're right that can essentially kind of escape, what's called escape, where it reads through the change and it does make the protein, but it's kind of a different sort of protein. But again, like there are a bunch that tend to be more in this region, but it is a much larger exon, and so it's just been very hard to say if that again is the case, that issue of nonsense mediated decay could account for that or not. But again, there are a number of individuals who have changes down here who have significant speech and learning issues, and others that are much higher functioning.
Okay, thank you so much, Dr. Sutton.